today's episode, we're going to review Chapter 7 of the Practical Guide to Transcranial Direct Current Stimulation, Principles, Procedures, and Applications. In Chapter 7, we're going to look at the methodological considerations for selection of tDCS approach, protocols, and devices. In this review of Chapter 7, we're going to look at methodological considerations for selection of transcranial direct current stimulation approach, protocols, and devices. So we're going to look at how to do tDCS properly, protocol, device, and design decisions that matter. Today's episode is going to involve a deep dive into an important topic, but one that's often overlooked, areas of tDCS methodology. How can you set up a tDCS research study or clinical session? The way that you set up your tDCS research study or clinical session can make or break your results. So let's explore what goes into choosing the right approach, whether you're working in a lab, a clinic, or exploring home-based remote supervision use. So why does methodology matter in tDCS? It might seem like tDCS is a simple tool. 2 electrodes, low current, and go. But in reality, the effectiveness and replicability of tDCS depends on a long list of factors. Things like electrode size and placement, stimulation intensity and duration, session frequency and course duration, and whether stimulation is applied during a task or at rest. Even minor changes in these variables can lead to different outcomes, and that's why evidence-based and carefully considered protocol design is essential. So let's look at the tDCS decision matrix. The chapter introduces a decision-making framework that includes questions like, is tDCS indicated for this particular patient? What polarity should be used, an anodal or cathodal? What montage or placement of electrodes, and what electrode size is going to be optimal? Is the stimulation uni-site, bi-site, or multi-site? What frequency and duration of treatment is going to be best? This is all visualized in a clinical decision tree, which is figure 7.5 in the textbook, and we'll show that here. And this guides the clinician from the clinical question through to the protocol selection. So now we're going to define the goal: research, enhancement, or therapy. So the protocol should begin with identifying your goal. Are you trying to explore cortical function in a research setting? Are you trying to enhance cognition or motor skills in a neuroenhancement or neurorehabilitation setting? Or are you trying to treat a condition like depression or, again, stroke recovery in a therapeutic sense? Each of these goals comes with a different design need. For example, cognitive enhancement might benefit from short repeated sessions, where rehabilitation might require longer, high-frequency type protocols. So what are some key variables in protocol design? Let's talk about the big dials, so to speak, that you can adjust. The first is electrode size and placement. Smaller electrodes is going to equal greater focality. It's not hard to imagine that if you have a smaller electrode with a smaller scalp contact, it's going to lead to a greater focality of electrical current. Larger electrodes, on the other hand, are going to lead to a more diffuse current application. The second is stimulation site, which we're going to choose based on the network activity and not just that underlying neuroanatomy. Remember, no brain region works in isolation. The third is montage type, montage or placement. There's cephalic, so-called cephalic, C-E-P-H-A-L-I-C, which is both electrodes on the head. There's extracephalic, which is involving a return electrode on another part of the body, like on the shoulder or arm. And there can be dual site or multi-site for complex network modulation. The fourth is timing. So online during a task, like a motor task, a learning task, an emotional task, or some other sort of activity that a person's doing in terms of movement or thinking or feeling, versus offline, which would be before or after a task. So stimulation before or after a task, but technically at rest. Online appears to yield stronger behavioral effects in the studies that are considering differences here. Online appears to yield stronger behavioral effects in those particular studies that are looking at differences in terms of online versus offline effects. Now let's have a look at standalone tDCS versus adjunctive tDCS. So tDCS by itself versus tDCS in combination with another treatment modality. This is a question. Should tDCS be used by itself, or is it best when paired with something else or even multiple other treatment options at the same time? Examples could include pain management. Pain management, is it best with tDCS alone or in combination with other types of pain management strategies? Stroke rehabilitation, perhaps using combinations of tDCS and active physiotherapy. Depression treatment, perhaps using tDCS in combination with medications like SSRIs and or psychotherapy like cognitive behavioral therapy. So remember, when we're combining treatments, we want to use factorial designs in order to test for synergy between combined treatment modalities, like was used in the so-called Select tDCS trial for treatment of depression. Now let's look at some population-specific considerations. Certain special populations require even more tailored protocols. For example, children with smaller heads is going to involve an inherently different current flow. So use of lower intensities and close monitoring for side effects will be important. In older adults, because of the cortical atrophy that occurs during aging, that leads to a greater gap between the outer surface of the cortex and the inner surface of the skull, so that there's more CSF or cerebrospinal fluid outside of the brain bathing the brain. That can lead to altered current distribution in terms of direct current emanating from the electrode on the outside of the scalp, traveling through the scalp, then through the tissues that are underneath the scalp, the so-called dura, through the CSF, and eventually to the cerebral cortex itself. This may require different electrode montages or longer ramp times. What about certain neurologic or psychiatric conditions? Well, custom electrode placement may improve outcome in a condition-dependent manner. So, for example, monitoring for medication interactions or symptom fluctuation during tDCS can lead to descriptions that might be important in terms of identifying commonalities that can then be integrated into treatment protocols. Now let's look at some differences between clinic-based versus home-based device use. Certified tDCS devices fall into two main categories. There are clinic-based devices, which are typically programmable, often used in clinical trials or in hospitals or outpatient clinics. And then there are home-based devices, which typically will be also programmable, but then once they're programmed, the settings are locked to prevent people from interfering with the clinically prescribed and carefully selected settings. And the use then is often remotely supervised via telehealth or another way of the patient staying in contact with the practitioner, and in order to provide real-time assistance and direction in terms of the setup, and in order to make sure that the device is being used in a safe manner. So for selecting a device, it's important to consider things like the stability of the current that's being delivered, the ramp features, so the ramp being the intensity of the current from zero current all the way up to the prescribed full current and how long that takes. And then on the other hand, when the session is finished, when the ramp is going from the full current down to zero again. So electrode impedance checks to make sure that the actual contact between the electrode and the scalp is optimized. And then in research studies, appropriate blinding capabilities for sham treatments to compare with actual treatments. Now let's have a look at the session frequency and repetition. So how often should tDCS be delivered? The old rule was longer is better, but research has really shown that excessively long stimulation may actually trigger homeostatic counter-regulation. So the brain is a homeostatic, the nervous system, altogether, and really you could expand that to say that the body altogether is a homeostatic system. If there's a change, the brain in particular will seek to counteract that change in order to maintain a balanced state. So studies showed that excessively long tDCS stimulation is potentially going to trigger the brain's response in terms of a homeostatic counter-regulation, which may in the end kind of undo the positive therapeutic effects of shorter stimulation with tDCS. So instead, in order to find the sweet spot in between those two states, the normal state where there are target symptoms and the excessive tDCS state where the brain kind of counteracts what the tDCS is trying to do in a therapeutic sense, what is being shown is that repeated shorter tDCS sessions over the course of a day is inducing more robust therapeutic effects. And so this is what's known as within session repetition, and it can produce effects that are lasting up to 24 hours in one particular session time. What about integration with behavioral tasks? So it's becoming clear that when you combine tDCS with certain tasks, amazing things can happen. For example, faster learning, greater retention of information, and improvement of mood. But there is also a flip side. Certain studies are showing a potential interference between stimulation and task performance if it's poorly timed or mismatched. So what appears to be important is to align the task type, the stimulation target, and the session schedule very carefully. So some final thoughts. It's important to look at this as a methodological toolbox. Designing effective tDCS protocols appears to be a combination of art and science. You need to match your stimulation parameters to your goal. You need to consider the population that you're treating. You need to choose devices and montages or electrode placements that are based on feasibility and scientific rigor. You need to test and refine through careful measurement and reporting if it's a study. And the more standardized and transparent our methods are going to be, the faster the field will be able to move forward. And for research protocols, obviously, it's important to test and refine through careful measurement and reporting. So the more standardized and transparent that our methods are, the faster that the field will move forward. Thanks again for joining me for this deep dive into tDCS methodology. Whether you're a researcher or a clinician or someone who's just curious about how all this is being done, it's important to remember that how you set up your stimulation protocol matters as much as whether you stimulate at all. Just a quick reminder to please like and subscribe to the podcast. It's the best way to ensure that you never miss an episode. I would also encourage you to share this with someone that you think might benefit from understanding more about this revolutionary technology, someone who's involved with the early stages of designing research, or someone who's interested in integrating this into their clinical practice. And please leave a comment or ask a question in the comment section below. Please also suggest a topic that you'd like us to review in a future episode. So until next time, don't forget to tune in to the next episode, and I will see you there. Please stay well, stay curious, and we'll see you again on the Neurostimulation Podcast.